Assalamu alaikum, Saleh. It's a pleasure to be here again, and just want to put my own timer in. Okay, this is, first of all, I would like to thank Professor Ali Aldasouqi for inviting me, as well as I would like to thank all his colleagues in the Congress board. This is my seventh trip to Egypt and my third to this wonderful meeting. And so, I'm going to be talking, well, my presentation is a little bit different. No research, no p-values, nothing. Just relax, a quick, kind of like quick guide, maybe some tricks, some caveats of how to interpret thyroid functions in a quick way. And so, so that was my first slide. And these are some sweet memories from 2014 when we were invited to this wonderful meeting with Dr. Bardar. So I'm going to present 7 cases quickly, and then give some guide, and then try to analyze the cases and try to solve the mystery in each. So this is the thyroid surface markings, and if you cut the skin open, then of course post-mortem, right? So this is the thyroid, which is a nice butterfly, right? So it's a nice butterfly organ. And this is the imaging technique, the most popular. This is how thyroid looks like in transverse section. This is how we do the biopsy. And it's really a butterfly. And this is, a real butterfly. There's a video here, but I won't skip it. But I took this picture myself. And these are also real butterflies from Michigan. These are not real, these are plastic butterflies. And this is a blog I wrote a month ago describing the thyroid as a butterfly. So the major issues about thyroid are usually nodules and cancer and goiter. And on the anatomical side of things there, and the function side, we have hyperthyroidism, hypothyroidism, and therefore thyroid function tests. And according to Ringel and Mazafiri, it seems again just like the increase in the prevalence and incidence of thyroid nodules and thyroid cancer due to a lot of imaging, like car accidents, etc. We also have the same abnormal thyroid function just from because everybody coming to the ER or for whatever specific or non-specific symptom, everybody gets TSH. So, just like for example, this patient who I saw some time ago, who put in her review system that she has all the symptoms of hypothyroidism, all of them according to her statement. And I'm sure this sounds familiar, right? So we see that all the time. And interestingly, she put the weight problem, skin dryness and fatigue, etc., together with tremors, which doesn't make sense, right? They don't go together. And what she's talking about, her thyroid being low, is this being low. So that tells you the lack of education and the lack of understanding of thyroid functions test amongst our patients. So obviously, given all of these symptoms of hypothyroidism and so on, we just blame it all on the thyroid. And this is a patient who has that actually on his t-shirt and covering the face to protect the identity of the patient. So this is a case, a generic case. If you get a TSH of 6, and T4 of 3, T4 of 1. So pretty much this could be a lot of things, right? Could be subclinical hypothyroidism, could be actually maybe hyperthyroidism of the T3 component, with the TSH being falsely elevated due to the heterophile antibody and so on. So when you look at this, more than one impression or diagnosis can come to mind. Just like looking at this picture, right? You all appreciate that this young man, when you look at the picture, can either be looking at you or can be looking back, right? So, is that clear to everybody? So this is just an example, just to keep you awake. Okay. So with that said, let's come to the first case. So the first case is this 21-year-old woman. She's pregnant, 11 weeks of gestation. She presents with vomiting and anxiety. T4 is 13.8 and T3 is 190. So how to interpret this set of thyroid functions? Of course, in the real world, you will get more history, more information, etc., etc. But this picture, more than one thing can come to mind, right? So let's look at the second case, which is exactly a similar presentation, a little bit older. She's also pregnant, around the same gestational age, 10 weeks, again presenting with vomiting and pretty much similar numbers. So I didn't give all the information here for a purpose, so that because we really need to know all the story and all the whole picture, all the picture. Now, case 3 is a patient that I actually saw many years ago, and she said, my family doctor was puzzled by my thyroid function test and could not figure them out. And she was clinically not hypothyroid. And the numbers are TSH undetectable and T4 undetectable. And yes, she's alive and she's walking and talking and she's not hypothyroid. Okay? So, go figure. And case 4 is a 21-year-old woman who I saw when I was a fellow. I'm not going to say when, just not to tell my age, but it was many years ago. And so this woman had a quote-unquote diagnosis of Graves' disease at age 15. She underwent radioactive ablation, and she is now on a very high dose of thyroxine. Clinically, she is relatively short. She's anxious. Her heart rate is 110. She has a small gland from the effect of the radiation. And her DTRs, these tendon reflexes, they were slow. They had slow relaxation. And look at the TSH, elevated, 6.4. Free T4 is also elevated. Okay? So try to figure that out. The next is case 5, a 61-year-old woman, postmenopausal. In January of 2005, her TSH, again just remember the generic case that I presented, 6.1. T4 was not done. She was then referred to us. So what was the first impression? So think about that. And then that was in January of 5. So in July, like 6 months later, look at what happened. TSH is now 1.8 from 6.1. Free T4, I ordered it because I'm a smart endocrinologist. I'm just kidding. So I found the T4 to be low. Okay, see, she had a simple goiter. She was not on thyroid medications or relevant ones. And look at this, FSH and LH were both low. And remember, this is a postmenopausal woman, right? So think about that. And case 6, also I saw this patient many years ago, and her neurosurgeon referred her to us. He was very smart and very intelligent because she was reportedly diagnosed with a large pituitary tumor, quote unquote, and the prolactin was elevated. So he did one single test, Okay, I'm sure every one of you would know what that test was. That kept his knife away with my apology to Dr. McLeod and the surgeon colleagues here. So he said, I'm not going to touch it, I'm going to send it to an endocrinologist, and he did. So what was that test and what turned out to be a case? And the last case is actually a case that we saw some few years ago. And this patient actually, she was presented to the medical floor with multiple problems, but the main thing is that she was quite puffy, and she had an effusion, pleural pericardial and peritoneal effusion, and so the folks in internal medicine consulted us after they had consulted nephrology, gastroenterology, cardiology, etc., because they thought she had nephrotic syndrome, pericardiac or hepatic disease, and they consulted us because they were not sure, does she have a thyroid problem or not? Because look at this, TSH was only 4.9. So, and here's what happened. So the patient was seen by many consultants, residents, students, etc. And only 2 old physicians, senior if you wish, suspected a diagnosis of myxedema just from looking at the patient appearance. So if she is indeed myxedematous, why is TSH not high? So these are the 7 cases, and so checking my time, so good. So these are the pre-test cases. So let's move on and talk about a little bit of some quick caveats and hints about thyroid functions. So what do we order thyroid function test? To evaluate hormonal status for population screening, if that is the case, to monitor replacement, to evaluate goiter sometimes, to evaluate effects of medications, and sometimes in undiagnosed conditions where thyroid functions tests may be related, such as high prolactin, as you all know. So, how do we understand thyroid function tests? Well, first, what are our tools? These are the main tests that we use: TSH, total T4, and free T4, and these are the ranges according to our lab. And so, you always need to know your lab. And of course, there are some labs that use SI units, some labs that use, generic, whatever, American units, if you wish. So know your labs and know your numbers. And this is total T3 and free T3, as well as reverse T3, if at all you want to order the last one. And the next is we have to know the physiology and the chemistry of the thyroid, and of course, I'll skip the details, you all know that. And you have to understand very well, as I'm sure all of you do, the regulation, the hypothalamic pituitary thyroid axis regulation. So if you have all the picture in mind, then you will get to the right diagnosis. And this is very important, which is a slide that I took from a textbook some time ago, which talks about all the things that can affect thyroid function, from depression to dopamine, steroids. This is the heterophile antibody HAMA, secure thyroid condition here, and all the feedback mechanisms. So, of course, this is another talk, so I'll move on. And on the left is the extreme hypothyroid end of the spectrum. On the right is the extreme hyperthyroid. In the middle, my daughter at the time, presumably euthyroid. And thyroid spectrum is actually a continuum. Okay, it can go from hypothyroidism to hyperthyroidism, and so we have to remember that. And if you put the TSH in yellow and the T4 and T3 in white here, then the primary form, the two go opposite to each other, like you see here. And the secondary, as you know, they go together. So we always have to remember that. And thyroid hormones, they affect much of the body through the sympathetic system, and therefore you see that you've got a lot of symptoms of hypo and hyperthyroidism. And to me, it's like the gas in the car. Low gas, everything is low and slow. You push the gas or the benzene, and the acetic benzene, so everything goes fast and so on. So in hypothyroidism, everything is slow, and in hyperthyroidism, everything is rapid and fast. So TSH is the most important thyroid function test that we use. T4 could be complementary, it's not always needed. These should be obsolete by now. The T3 is in update. Anybody from the old generation remember this? I'm not sure if you guys here in Egypt still do it. Our lab still does it. If you want to order it in Michigan, they can do it for you. Free T3, sometimes we order it. And then total hormones, occasionally we order them. And of course, reverse T3, I only order them on the request of the patient. Sounds familiar? So, these are the thyroid numbers. And remember that we treat patients, not numbers, and remember the feedback inhibition. And so, for example, some caveats, remember lab artifacts, the heterophile antibody effect, which falsely raised the TSH. Remember non-thyroidal illness, CQ thyroid. Remember medications, numerous medications affect absorption, etc. Of the thyroid metabolism. And remember lab glitches, just as simple as wrong sample, wrong name of these things, and you go figure. And of course, remember what medication your patient is on. Is the patient on levothyroxine or triiodothyronine or a combination, and so on. Compliance percentage is also important. And remember transitional states after surgery, after radioactive iodine, and so on. So remember all of that. Remember that sometimes to please the doctor, the patient would be non-compliant for some time, and they only become compliant the week before the appointment, so they come in with a still high TSH because it didn't have time to come down, but the T4 is low. So think about all of these possibilities. And again, these are the only references perhaps that I'm using about the effects of depression on TSH, false elevation, the effect of pulsatile nature of TSH secretion, heterophile, we mentioned that, and so on. So remember these. And remember that TSH is the best test, the most reliable, the most specific and sensitive, but remember it can be deceiving. It can be deceiving in secondary hypothyroidism. It can be deceiving in the heterophile effect. It can be also deceiving in pituitary tumors as well as resistance to thyroid hormone. And of course, remember medications. So, let's see what happened to these patients. So the first case, this is just a repeat of what we know by now. This is what we also know now. So this patient, so if you look at these numbers here, deliberately I didn't specify what they were, but they were actually total. Okay, so they were total free T4 and T3. So they are minimally elevated. If this is a free and this is free, this is going to be hugely elevated. And so this patient had a suppressed TSH, and so these two hormones are indeed elevated. So then now it becomes clear that this patient has probably gestational thyrotoxicosis. Probably, because also Graves' disease coincident with pregnancy can also be the case. Okay, we don't do radioactive iodine scan and uptake in pregnant women, as you know. So gestational thyrotoxicosis and pregnancy-associated Graves' disease are pretty much indistinguishable, except that if you take a very good history, you'll know that the symptoms and the presentation in the former, let's say gestational thyrotoxicosis, the presentation is very brief. You're talking weeks. While in Graves' disease, usually the patients are there for at least a year or so. So the goiter is going to be different, and the bruit, etc., are going to be different. Of course, eye symptoms also are different. Case 2 is a little bit tricky because here actually this woman, although she's very similar to the first case, this woman, I'm giving you now the information that the TSH was normal, okay, unlike the first one. And now, since these are total hormones, they are indeed elevated. But if you do the free T4 and T3, it's going to be normal. So that now is easy because this is just the effect of the gestational estrogen. And you know, estrogen changes the dynamics of the protein binding, and so you get falsely elevated total hormones, but the free hormones are normal. No treatment is needed. Now, case 3, I'm sure I'm sure all of you knew that. So this patient, look at this. TSH is suppressed and T4 is undetectable. So the patient was on Cytonib or triiodothyronine. Okay? And remember, T4 can be converted to T3, but not vice versa. And so if you order T3, it's going to be very high, right? And the patient actually was hyperthyroid. Okay, that's why I said she was not hypothyroid. In fact, she was hyperthyroid, a little bit clinically. And case 4 actually is a classical case of resistance to thyroid hormone. So these are the folks who have symptoms of hyper and hypothyroidism together in the same body, in the same human being. This is typical of resistance to thyroid hormone. And the TSH, because of the resistance, is going to be always elevated. In the next case, it's obvious now that the first part was a subclinical hypothyroidism, and so obviously the patient was minimally clinically hypothyroid. And so after that, what happened is that the patient in the interim developed some problem in her pituitary. I think it was hypophysitis, or let's say sarcoidosis, where you have secondary hypothyroidism. And hence, while she is postmenopausal, she should actually have elevated FSH and LH. And so this is the trick here. And so that was the diagnosis. And I just told you everything. And case 6, it's obvious that this patient had severe hypothyroidism that caused hyperplasia of the pituitary, masquerading and mimicking pituitary tumor. Okay? So the doctor, the neurosurgeon, ordered TSH, and this is what we found. We only gave her thyroxine, and everything went back to normal. So no surgery, no neurosurgery, no tumor action. And case number 7, actually, I only have less than 1 minute. So in this patient, what happened is that she was severely myxedematous, and TSH was not elevated because she had CQ thyroid, she had empty cellular, so she had actually secondary hypothyroidism. So the TSH was falsely low or normal, was falsely inappropriately low for severe hypothyroidism. And that tells us the importance of good history, taking history and doing good physical exam. I don't know about you folks here in Egypt, but the new generation in America, physicians, they're not really that much on physical exam. You show them a textbook myxedema patient, they cannot tell. That's unfortunate. So I'll stop here. Thank you.